My name is Robert Lerrigo. I am a gastroenterologist, just graduated fellowship from Stanford, and I have a special interest in inflammatory bowel disease.
My name is Cindy Coelho. I'm a Gali ambassador. I've had Crohn's for just about 2 years when I was diagnosed, but in hindsight, probably been more like a mild case for around 15 years. So I kind of got involved with the Crohn's and Colitis Foundation, trying to fundraise and start being an advocate. And I've also been involved with the piano study through UCSF.
Yeah.
Professionally, I'm a dietitian, but I don't specialize in care of IBD patients, but get a few here and there. So I had kind of a general question about quality of care for IBD patients. And this could pertain to folks that maybe are newly diagnosed, trying to learning to navigate the healthcare system. But what's really the difference in quality of care a patient might receive if they are followed by a GI that specializes in IBD versus just kind of a general GI doctor?
Yeah, that's a really good question. I don't think there's really enough objective evidence out there to suggest that patients in general are getting better or worse care from one type of gastroenterologist versus another, a general gastroenterologist versus an IBD specialist. Taking a step back, just to kind of delve into the type of training that people undergo. So after residency, all gastroenterologists undergo 3 years of gastroenterology training through fellowship. And as part of fellowship, they have to learn about inflammatory bowel disease. And a part of that should ideally involve, actually seeing patients with inflammatory bowel disease. Now you can imagine different fellowship centers in the country have different numbers of inflammatory bowel disease patients. If you were to train at Mount Sinai, for example, huge Ashkenazi Hasidic Jewish population with IBD, a huge IBD population, the fellows who graduate from that program get more than enough IBD exposure, and they don't necessarily need to undergo additional training within IBD to be considered an IBD specialist. If the gastroenterology fellow doesn't feel like they're getting enough IBD experience at their home center, then they can decide to get an additional year of fellowship training at a major IBD center. Or they can seek kind of outside experiences through away rotations, for example. So I did an away rotation at Mount Sinai. Stanford sees a lot of IBD patients in and of itself, but I spent a month at Mount Sinai through the Crohn's and Colitis Foundation, talking to their providers, seeing patients, etc. And so gastroenterologists in the community and in academia, they usually or sometimes they have a niche and they say, I'm the esophagus guy, or I'm the motility guy, or I'm the guy who sees just IBD patients. More often than not, people are kind of a generalist. They see all sorts of patients, but they may focus particularly on one type or another. It's really not clear as to whether, if you have IBD, whether you should be seeing a general gastroenterologist or an IBD specialist. If gastroenterologists don't feel comfortable taking care of a particular patient with IBD or whatever other disease process that they haven't seen a lot of in training or in practice, they may refer them to other providers who have. Sometimes there are resources that are available in another center that are not available at your center for taking care of IBD patients. And that's another reason for referring outside. But I think you should feel confident that if the gastroenterologist you're seeing is confident enough to kind of accept you as a patient and manage you, that they are comfortable managing. However, having said that, it's never ever wrong to request a second opinion, third opinion, particularly on complicated issues. And a lot of times gastroenterologists will kind of initiate that discussion. They'll say, I think moving on to surgery is probably the best way, or I think switching you to this new medication, IBD medication, is the way to go, but I haven't prescribed this medication to a lot of people, and I'd feel more comfortable requesting second opinion or third opinion, so I'm going to send you to Dr. So-and-so. So that's done quite frequently. But again, it all relies on communication between you and your provider, and just know that there are several options. And I'm not sure if there truly is a quality of care difference between a general gastroenterologist and someone who has a particular interest in IBD. My feeling is no. Usually we're pretty good about referring patients to specialist providers if we feel uncomfortable with treating a particular gastroenterologic disease.
Kind of wondering, like, would it be appropriate, a patient seeing a new GI doc, to ask their comfort level with IBD? And because how much should the patient advocate for themselves?
Yeah, I think that's perfectly appropriate to ask them. A lot of times, and again, it's difficult to say because every patient's different, and their IBD manifests in different ways. So patients with very well controlled, ulcerative colitis, who are minimally symptomatic or completely no symptoms, any gastroenterologist should feel comfortable taking care of them, especially if they're well controlled or well managed. And others with a more complicated history who come in with, a huge Bible thick worth of notes, should also feel comfortable asking their gastroenterologist if they think they're the right provider for them to see, if they've had enough experience or expertise in treating IBD. I think people should feel comfortable asking those questions, and you should be able to get a straight answer.